and thank you, Dr. Dukipati and Dr. Reddy, for inviting me. It's a real honor to be virtually here with you. I know that it's very early morning in US, so I hope that all of you have already got the coffee. Otherwise, you can sleep during my presentation if you feel that it's not very interesting. So just switch off the camera. Just don't see your faces sleeping. No, I'm joking. So it's an honor. I will share my screen, and I will share with you our thoughts of our team in Clinic Hospital in Barcelona about our strategy in BT ablation, that mainly it's combining both imaging and mapping. So the first question that I would like to ask you is, why do we need imaging and S3 mapping in BT ablation? And I think this is really important, because if you see the last results of observational studies and randomized trials in BT ablation, even the last ones like the post-sudden cardiac death trial of Rotang or the Partita trial of Paolo Della Bella, even in the best hands of BT specialists, you have more than 30% of recurrence, usually at 2 years. So in BT ablation, we are dealing also with some kind of failures. To me, a failure is just a first attempt in learning. And that's why I think it's very interesting to analyze this very elegant paper from a Bordeaux group, already published in JICE some years ago, in which they analyzed the substrate that they found in the redo procedures. First of all, in the first view, you can see that there is some progression of the scar in 50% of the procedures. So you could consider, okay, it's patient's fault. It's not my fault because it's a progression of the disease. But if you go more into the detail in this study, they had exactly the same BT morphology in 40%. And not only this, but more important, they had to deliver radiofrequency at the same site in 70% of the patients. So it's true that there is some kind of a scar progression, especially non-ischemic disease, but there is also an incomplete first ablation procedure. So it's also our fault. And BT, it's all about substrate. So we need to really abolish the substrate. This study, it's very well known by all of you, the VISTA trial from Luigi Di Biase some years ago, that they compared they randomized just ablating the BT, the clinical VT or the induced VT versus scar homogenization. So substrate, very extensive ablation. And you can see I was silenced, I don't know why. Okay, I will share again. So they proved that ablating the full substrate was much better than clinical VT ablation regarding the recurrence rate. And this has been reproduced by several groups. It is a very interesting paper from Paolo Della Bella in Milano, that they found that if you render the patient non-inducible and you abolish all the late potentials, the recurrence rate in 3 or 4 years is less than 30%. So it's okay. However, if you render the patient non-inducible, but you do not ablate the full substrate, the recurrence rate in 2-3 years, it's like flipping a coin. It's 50%. So non-inducibility, it's a must, but it's not enough as an endpoint. And what is the problem with BT substrate? The problem is that we are working with electroanatomical mapping systems, and this is a planar method. So with Insight, Carter, Rhythmia, whatever system you use, we are working in the endo or in the epi, but we are working in the 2D. But BT substrate, it's 3D. Actually, in this paper from Rotang, even in the patients in whom you can delineate the full circuit in the endo, there is some part of the circuit that it's mid-mural. And it's the same case if you can delineate the circuit in the epi, there is always some part that it's inside the wall. And there are some patients in whom you cannot find the full circuit, neither in the epi, neither in the endo, because the diastolic part of the circuit is in the mid-mural. So imagine that you have a tool that can give you the full 3D substrate of the patient. And this is imaging. And actually, substrate, it's not only 3D, but it's also very variable from one patient to another. This is a study from Katja Zeppenfeld in Leiden, in which they analyzed 9 patients that underwent VT ablation and then underwent cardiac transplantation. So they had the tissue. They found that the pattern of fibrosis and the architecture of the fibrosis can be very different, can be subepicardium, transmural, midwall, whatever. So imaging can give you an idea about where is the substrate, how is the substrate, and very important, how depth is the substrate. So this is the role of imaging in VT ablation. And the question is, before the procedure, what can imaging tell us? So we use other software. I have no conflict of interest, unfortunately, with other software. So no stock options, no owner area, but it's the software that was developed some years ago in our institution. And that's why we use it routinely. And usually other software use late gadolinium enhancement MRI. So you give the raw data of normal late gadolinium enhancement, 1.5 Teslas, 3 Teslas, whatever. And then the software calculates automatically where is the maximum intensity of late gadolinium. This is 100%. That probably is around here. And then from 100% to 60%, it's considered core scar. From 60% to 40%, it's considered border zone in yellow. And from 40% to 0 gadolinium, it's considered healthy tissue. These thresholds have been validated by our group with SmartTouch, with Pentaray, with EduGrid, and with Tacticat. So it's a pretty robust thresholds. And then it gives you a 3-dimensional idea about how is the scar. And what I think it's more interesting is that it gives you the idea of the distribution of the scar from the endocardium to the epicardium. Imagine that you cut the total wall thickness of the left ventricle in the short axis, you cut it, and then you have 10% layer in the endo, 20, 30, 40, 50, 60, 70, 80, and 90, and then you can see the evolution of the scar from the endocardium to the epicardium. And you can have these layers in your cardio system and your NSAID system and your arrhythmia system. And you can change during the procedure from one layer to another. You can see, for instance, in this example, that you have a very extensive transmural anterior scar that starts in the endo and ends in the epi. But what is more interesting in this example is that the channel, so the area of border zone that crosses the core scar and connects to areas of healthy tissue, that is what we consider a conducting channel, like a voltage channel in your mapping system. It's not in the endo, but it's in the epi. It's in the 60, 70, and 80. So this is an ischemic patient with transmural scar with an epicardial channel. So you have a lot of information in this first view of late gadolinium enhancement, MRI. But are these channels related with arrhythmias? And that's what we tried to figure out some years ago. We recruited 200 consecutive patients with ICD and primary prevention with a pre-implantation MRI. And we had 3 groups: patients with a scar and channels, patients with a scar without channels, and patients without the scar, like the typical Danish patient. And we figure out that with a follow-up of 6 years, the presence of channels was really related with appropriate ICD therapies. So patients with channels had 35% of appropriate ICD therapies in 6 years, so almost more than 5% of ICD therapies per year. And patients, remember, with depressed ejection fraction, so primary prevention ICD indication, but without channels, less than 9% of ICD therapies in 6 years. So the answer is yes, these channels are related clinically with arrhythmias. Actually, the presence of channels and the distribution of channels in the pre-ablation MRI, it's also interesting to see, to be used as a predictor of recurrence. So in this study, in more than 100 patients, we figure out that the extension of the scar is important, but it's much more important about the extension of the channel and where is located the channel. Look at this patient with a huge scar, but purely endocardial channels. So this patient has low risk of recurrence after ablation. The opposite one, extensive scar and transmural channel, high risk for recurrence. And very important, very limited scar, but very mid-mural channel, high risk for recurrence. So MRI can give you where is the channel and if this patient will have recurrence, yes or not. And finally, in terms of relation of the MRI with rhythmogenicity, we correlated the deceleration zones, the ILAM maps, with the channels in the MRI. So we already proved that channels matters in terms of clinical events. And with this study, we try to prove that channels of the MRI are related with endocardial slow conduction areas, in this case with deceleration zones. If you see this S1 propagation map of an epicardial map, you see nicely 3 deceleration zones, one here, and sorry because it's another one missing here. And all of these 3 deceleration zones are located in this channel, and this channel. And actually, we proved that more than 90% of deceleration zones were located in MRI channels. So we proved again the homogeneity of these MRI channels. Coming back to our patient, I've told you before that the substrate of BT is 3D. So if we see this MRI, we all agreed that you have an extensive transmural scar and epicardial channel. So the question is, shall we go to the epicardium from the very beginning? Well, we need more information because we need the information about the third dimension. And what is the third dimension? The wall thickness. So using MRI or using CT, you can have also a wall thickness map. This map with the same MRI, it's the same colors that I showed you with the late gadolinium, but different information. In this case, red is what the areas with less than 5 millimeters of wall thickness, sorry. In blue is more than 10 millimeters, and in yellow is in between. And you can play with these thresholds during the case, the BT ablation case, if you use Inside. If you use Carter, you have to decide in advance the thresholds, but if you use Inside, you can play during the case. You will see in the last part of the presentation. So if you see the entrance and the exit of this channel, it's in an area of less than 5 millimeters. So 60% of 5 millimeters, it's 3 millimeters. So by using this third dimension, the wall thickness, we decided in this case to go just in the endo, despite the channel was located in the epi, because this area was very thin. And if you see now the propagation map of the BT, you see nicely the diastolic potentials at the entrance of this epicardial channel, because it's epicardial, but it's so close to your catheter in the endocardium that you can map and you can ablate from the inside. And actually, we ablated during BT, and the BT stopped in less than 30 seconds, despite it was an epicardial channel. So that's a very important information from the MRI or the CT, the wall thickness. And actually, the wall thickness, it's being used in our lab routinely, and now we are using the wall thickness map to decide if we can ablate the substrate from the endo or we have to go to the epi. And this is unpublished data. It was presented as an abstract in the BT symposium, but it's not published yet. So please do not publish before we do. And we follow up more than 50 patients in whom we went just endo. And we realized that if the channel was located more than 7.5 millimeters from the endo, the recurrence rate was very high if we just ablate from the endocardium. So we are using like 7 to 8 millimeters as a threshold now to decide to go to the epi from the very beginning. Also, we tailor our ablation based on imaging. We decide the endo-epi approach. We titrate our power and our ablation time depending on the wall thickness. And you will see in the last part of the presentation when I will share with you a live case. Also, the CT wall thickness map can be used to see corridors, to see channels. So if you have no availability of the late gadolinium enhancement and you have an ischemic patient, you can practice a CT, and with the CT wall thickness, you can also see channels. What is a channel in the CT wall thickness? If you think in an ischemic scar, Ischemic scar is an area of wall thinning. So the viable tissue inside the scar will be the thickest part in this wall thinning area. And this is how can you see the CT wall thickness corridors. This is an area of wall thinning, and this is the thinnest area. This is the thinnest area, and in the middle, you have a thicker area. So this is a CT wall thickness corridor. So if you have no possibility of getting an MRI in an ischemic patient, you can also see channels in the CT. And what about during the procedure? What about imaging during the procedure? So during the procedure imaging, it's important to assess anatomical challenges and to assess very small scars that you are not sure with the mapping. Look at this very early stage left ventricular dysplasia. This is an epicardial map with two very small scars, not very fancy late potentials. Is this scar real? Yes, it is, because look at the 80% layer, so epicardial layer of this patient in the left ventricle. Two small scars, very similar to the scars that we saw in the voltage map in this epicardial map. And also the latest potentials that I assume it's not very late at that stage where we're not doing S3 map. Probably with S3 map, we could unmask more late potentials here. But this area of late potentials, it's very close to this small scar. So in this case, MRI was very helpful to reassure that this very small area of not very sexy late potentials was real. And on top of that, because we had also CT in this patient, we merged the CT, so we had the coronary artery, so we didn't need to do an invasive coronary angio to do the ablation in the epicardium in this patient. Another scenario very useful for imaging is the deep substrate. So if you have a deep substrate, look at the late potentials map in this patient. This is the latest potential, not very late, because this is atrium, so not very late. Is this really substrate, yes or not? So again, this area, it's very close to the exit of this intramural layer, intramural channel, sorry, because it's in the 60%. So we try to induce like hell in this patient based on this channel, and we found the exit of the BT, and we increased the power to 50 watts. We delivered lung lesion, and the BT stops, and we homogenized this area based mainly not on late potentials, not in voltage, but on intramural MRI channel. Look at this example. In this example, you see the papillary muscles that you can also delineate with the MRI in the CT. So you can integrate in your inside system or in your cardiac system the papillary muscles, and you see all the channels that are located in the inferior infarction. I will move it again. This is an inferior infarction. You look at the inside model. Sorry, I will come back. Sorry, because the computer is going down. Okay, so I will move the video again. Okay, if the video doesn't move, don't worry, but you see that you have a lot of substrate in the inferior wall that is some kind protected by the papillary muscles. So you have this information in advance with your imaging. So then you can think, okay, this will be tough. And not only this, but but we have to find some, some strategies to go around the papillary muscles to do the ablation. Sorry, because this video, it worked, but I don't know why it's not working now. I will try to skip this slide. Sorry, I will stop sharing. Sorry about that. Okay, so I will share again. Okay, so so if you see the island map of this patient, you see that sorry, I don't know why. Okay, I will start again. So if you see the island map of this patient, all the deceleration zone is located in this channel. This is a merged island map with the channels of the MRI. This is how we work. And you see that all of this area is protected by papillary muscles. So if you see the video now, you can ablate with the papillary muscles in your inside system, and you see how difficult it was to really go around the papillary muscles, but it was very helpful to have the papillary muscles during the procedure to move the catheter. And let's move to the S3, because if imaging is so nice, why do we need mapping? So look at this MRI of this inferior infarction. If you have this kind of substrate, and we have to ablate the substrate, you can use different strategies. You can go to scarlet channeling, what I think is very elegant, but it only works if it's 2D. You can use core isolation. You can use lava or late potentials, or you can kill the scar. So you can use scar homogenization that actually probably is the most effective. But at the end of the day, you have to make sure that you have abolished the slow conduction. And you can do this only by using mapping. And actually, if you use this, if you see this patient with this kind of a lot of channels, do we have to ablate everything? If you use just imaging, yes, you have to ablate everything. But if you use mapping on top of this, you see that this area is the area with a desiccation zone. And also this area is an area of a second desiccation zone. But you don't have to ablate this area, you don't have to ablate this area, or this area probably. So by using mapping, you can refine your area of ablation. And actually the BT exit of this patient was exactly at this point. So to answer this question, I will show you two papers from our group. To answer this question, do all channels have the same aerodynamicity? So we compared the MRI channels with the BT maps. And we found that mainly the BT isthmus was always located in the longest channel. We analyzed several parameters like length, ramification, mass of border zone in the channel, but mainly the length, the longest channel, was always the channel that was located, that was hosting the BT isthmus. But the second question, this is important, but the second question is, okay, but do all channels need to be ablated? And to answer these, what we did, and this is a paper under review, we analyzed all channels in our patients, and we analyzed which channels had deceleration zones. So had a slow conduction, not only BT isthmus, but also slow conduction properties. And we figured out that only 70% of the channels had a slow conduction in our maps. So the other way around, 30% of the channels do not need ablation because are not functionally active. And we again did the same analysis with more than 40 patients, more than 100 channels. And again, length was strongly associated with a slow conduction. Actually, if you see this example, two channels, one short channel, no deceleration zone, one very long channel, really deceleration zone. And actually, if the channel is in less than 10 millimeters, the possibility of having a slow conduction in terms of deceleration zone is less than 15%. So again, mapping is helpful to decide which channel need to be ablated. And finally, why do we need S3 mapping? Because of the same reason. Because by using imaging and by using S1 mapping, we still have recurrences. And actually, let's move to the deep part, decremented evoked potentials. If you add extra stimulus in your patient on top of your pacing train, you can find decremental potentials. And if you add an S3, you can increase its decremental properties. And that's important because decremental properties are the perfect substrate for reentry. And that's why Andrea Porter-Sanchez and Nanta Kumar in Canada tried to establish that just ablating the potentials with decremental properties, the deep potentials, you could ablate less and having the same results. So they compared the voltage map, they compared the late potentials map, and they compared the deep map. And you can see that the deep map is smallest area to ablate than the late potentials. And they found that the deep potentials are more specific in terms of correlation with BT isthmus, and that you can have the same results, 25% of recurrence in 1 year, with less area of ablation. However, by ablating just these potentials, you still have a lot of, to my point of view, high recurrence. This has been reproduced by several groups, by Katja Zeppenfeld group, by Antonio Barreto group, in our lab some years ago, by Barr's group with the SENSE protocol. And with SENSE protocol, they started to think how we think now. They compared sinus late potentials map with a map with extra stimulus, and they figure out that the area to ablate was higher by using extra stimulus. And actually, what we started to do is that we figure out that if we just use the S1 map, no extra stimulus, and look at this example, what happens is that you see some deceleration zone close to a channel. We ablated this deceleration zone, and in the remap, we find a new deceleration zone correlating with another channel. Finally, we ablated this area, and in the final remap, we have no deceleration zone. And this is not exceptional. So in more than 20–30% of the patients, if you just stick to S1 map, so without S3, in the remap, we have new deceleration zones. So the question is, can we improve our first substrate map to see the full picture, the full area of deceleration zones that you need to ablate, and then you do your ablation and you do your remap, and you have no surprises. You have no new areas to ablate, because this is very annoying after 3 hours of the procedure. Actually, US group also showed that S2 was better than S1. And also by using S3, you see not only, you unmask not only new areas to ablate, so we use S3 to ablate more, in the opposite that the origins of DIP. We ablate more than less. What I think is more important is that by using S3, you not only unmask areas of late potentials, but you also see patterns of propagation. Look at this very interesting example. By using S3, you see late potentials, but you also see, without any mapping, you see an area of deceleration zone. This area is a pattern of a conduction, a slow conduction pattern. You see that the conduction propagates from this red spline to green to blue or yellow, red spline, purple, white, and purple again. So this is an extremely important area that you have unmasked by using S3, even without any colors. Even more important, you can induce VT by using S3. And if you induce VT with this pattern of activation, with unidirectional block, you see that there is a pattern of activation here, because this 1920 becomes later than 1314, so it's a change of pattern of activation. And there is a block here in 3/4, there is a block, so it's a unidirectional block and a re-entry. So this is exactly how BT starts. So you can unmask patterns of activation by using S3, and you have to tag these areas, because these areas really, really maintain the BT. Look at this example. This is an example of a sinus map, ILAM sinus map, of two areas of isochronal crowding, one here and probably one here, not very clear. These channels are the channels of the MRI merged in your map. Compare with the S1 map. So you unmask more this area of deceleration zone, and also probably this area. Look at the S2 with nice area, new area of late potentials here. And the question is, why not S3? And please don't ask me the typical question about why not S4, because this will be the never-ending study, but I agree with you, why not S4? Look at the S3 map. We really, if you compare S2 with S3, you really see a lot of slow conduction in this channel, and also in this part of this channel, because you see a lot of colors. For those who are not using ILAM, remember that ILAM map is to divide the total activation time of the ventricle in 8 equally distributed isochrones. So what we are looking for, it's not for purple anymore, but for areas of 3 or more colors together. It's like the weather forecast. If you have 3 or more colors, you have slow conduction, you have BT. So the results of our study, of S3 BT free study, we collected more than 40 patients. We were able to perform the study in more than 85%. The protocol is S1 1600 milliseconds, S2 VRP plus 30, S3 VRP plus 50. We can discuss in the Q&A section why we use this. Typical population of BT ablation, 70-year-old of age, mainly male, mainly ischemic, but more than 20 non-ischemic, 30% of ejection fraction, mainly endocardial, but more than 50% epicardial. Procedure duration less than 4 hours. Radiofrequency time less than 40 minutes. So pretty less than, for instance, the scar homogenization, that it's an average of 60 minutes. And look at this example. This is an S1 map with a nice area of late potentials and deceleration zone here. Nice potentials. We induced BT. BT was using this area of late potentials as a diastolic isthmus. So we were happy. We ablated the patient. But if you look at the MRI, this first channel is correlating with this very long channel in the MRI. But what about this very long channel? I told you at the very beginning, long channels are related with slow conduction. So we have to do something to unmask slow conduction here. So look at the S2 map. With the S2 map, we start looking, finding late potentials in this second channel, and look at the S3 map. With the S3 map, we very, very nicely see two areas of late potentials correlating with these two very long channels. And we induced BT, a second BT, and the exit of the second BT was using this second area of late potentials, that is this second channel. So what are the results of this S3 study? By using S3, we statistically significantly increase the number of deceleration zones from 2 with S1, 2.5 with S2, and 3 to S3. If you measure the deceleration zone area, that it's really difficult to decide how to measure it, but if you measure it, you increase also the area of deceleration zone from 8 to 11 to 14. And if you go for late potentials evolution, and you measure the late potentials area, you also increase the area of late potentials. As always, it's bigger than the deceleration zone area, from 24 to 33 to 39. And if you look at this example, you can answer this final question. Okay, we are unmasking new deceleration zones. We are unmasking late potentials. But is this specific in terms of BT isthmus? I can tell you, I don't really care it, because I'm more in favor of substrate ablation. But however, if you analyze the number of BT isthmuses that you unmask with S3, I showed you this example in whom this exit of the BT was unmasked with S3, because this exit of the BT had no late potentials in the sinus, no late potentials in S1, small late potentials in S2, but clear late potentials in S3. And we analyzed this, and we found that the sensitivity to found the BT isthmus by substrate map increases from 75 in S1, 84 in S2, and 94 in S3, sorry. Recurrence rate in almost 2 years is less than 20%, but let's see the follow-up. And I will like to end the presentation by showing how do we use this S3 and imaging in our lab. So a case in a box. This is our workflow. Mainly we use transeptal. We have the MRI side by side and we merge it. You will see how we merge. Then we go for substrate evaluation. Because we merge, we only map the scar. We don't map the full ventricle. We only map the scar and around the scar. We don't use almost never voltage mapping. We use ILAM and the S3 map. We also try to figure out where is the clinical BT, and we ablate first the clinical BT and final the rest of the substrate. And when the substrate is done, we remap, and finally we reinduce. So how we prepare the case? This is how we do the case. This is our fellow that is doing the puncture. And when she is doing the puncture in this case, we always have the hemorrhoid inside the inside system. And we have the channels and we have all the layers. And then we can, again, like I did it in the first slides, we analyze the hemorrhoid during the puncture of the patient, or even better the day before, but we always are in a rush. So sometimes we do it during the first part of the procedure. And like the example that I showed you before, in this case, we have the typical endocardial scar with mainly a channel that affects from the 50, 60, and 70%. We always analyze the wall thickness map before starting the procedure. And in this case, we figure out that we had a hard case because we had more than 8 millimeters almost all over. It's true that in this channel, we have areas of less than 8 millimeters. So we decided to start an endo case. And again, we merged. Merging is useful because then you can navigate inside the hemorrhoid. How do we do the merging? Because we go for transeptal. You can see that with the HQ, we collect anatomy of the pulmonary arteries. And she is Dr. Vázquez, one of our senior fellows, collecting the anatomy of the pulmonary arteries. It's nice to have the bifurcation. Then I was probably a bit anxious and I took the catheter, but sorry about that. And then we collect just this part of anatomy. And now we take off the catheters. And in the meantime that you prepare for transeptal, you will see that now people from Insight or from Carto merge the pulmonary arteries from the CT or from the MRI with our system, with our pulmonary anatomy. And you can see that now the merging is done. And you see that the merging is pretty okay. So now we will be able to navigate inside the MRI. If you use the aorta, you can also merge with the aortic arch. It's pretty fast, but we don't use a retrograde approach almost never. Then we do the transeptal with Agilis. I will skip this for a matter of time, but we don't use the transeptal with the SL anymore. We go with the Agilis, usually without TOE, but you can use the TOE. Why I use the Agilis directly? Because then you don't need to do the interchange anymore. You see the transeptal now already done. Finally, you have to collect some point in the apex to fine-tune the merging, and then you are there. And then in the meantime, our bioengineer, our fellow, is preparing for the S3 protocol. And you can see that we have already the HQ in the apex, and you can see also nicely the already in the beginning of the map, because we already collect the first point, we collect the first point already in the scar because we have merged. And you can see the incremental potentials already from the very beginning. And actually, it's very nice to start the map inside the channel. Why? Because if you induce BT, you will have very nice information from the very beginning. You see that now we're starting the SC protocol. I'm mapping the scar. So you see how we work now. I will stop the video. I will stop the video 1 minute. How we work is in one side, we have the MRI channel merged and the map. And in the other side, you see the HQ navigating inside the MRI. And you can see that from the very beginning, we induce BT. And it's not a problem because we were already in the scar and we already found diastolic potentials inside the scar. Despite we couldn't do the map of the BT, but you can make a picture, you can make a tag in the diastolic potentials because we already started, thanks of merging the S3 map inside the MRI. So in the case that with S3 you induce BT from the very beginning, then what we do is we increase the coupling interval of the extra stimuli to do not induce the BT. So then by increasing the coupling interval, we are able to complete the map. We do the map just in the area of the scar. You see that we are not moving far from the scar. We are also tagging the points with more slow conduction in terms of decremental activity, just to make sure that at least this area is ablated. I will go farther. You have nice decremental activity inside this channel and in this channel. And then we do the turbo map of S1. just for research purpose at this time. And you see this is the S1 map with nice area of decremental slow conduction deceleration zone here and probably here, but no deceleration zone in this channel in S1. No deceleration zone in this channel in S2, just here. And if you look in the S3, you really see a nice area of deceleration zone. I will use the laser again, sorry. In this area that was not seen in S1, not in S2, not in sinus. A nice, huge area of deceleration zone in this area that probably it's the most important area you have to ablate. This is the comparison of these three mats. So in S1, you see 2 areas. In S2, you see 3 areas. Well, this area can be just 1. And in S3, you can see a lot of areas of deceleration zone that you have to ablate. Probably you can think that it's a pity if you have to ablate more, but probably I think for the patient it's better. Okay. If you see the propagation map in S1 compared with S2 and S3, look at the S3, you really see a nice deceleration zones in this channel and in this channel. So you can also do some pace mapping if you want. I will skip this for a matter of time, but again, before ablation, you know where to ablate. But by using wall thickness, you know how to ablate, because probably when we have to ablate to this area, and you can know it because you can navigate inside the wall thickness map, to ablate this area, you will need long duration applications. Sometimes high power, but mainly long duration application. In the other sense, in this area, because it's less than 5-6 millimeters, you don't need high power, you don't need long duration. And you see how now that we start ablation, we always use impedance drop to decide where to stop. With Tactiflex catheter, we use usually 30 watts. It's a very powerful catheter. So we start ablating in the main area of deceleration zone. We always start from the more critical area. And then we titrate our energy based on the wall thickness. You see that here we have changed to the late gadolinium to wall thickness. And here we will increase not only the power, but mainly the time. You see that we use 40, 50 watts, increase the power. And if the impedance drop, it's okay, we will last for 60, 90 seconds, or we will decrease the power. Look now, 55 watts, we will decrease the power and we will last for 2 or 3 minutes applications if it's really a wall thickness. Finally, we do a remap. You see the ablation set, and then we remap, and if we find some suspicious signal, then we ablate again, and we remap again with S3 with the same protocol. This is the first remap. This is the basal map. This is the first remap with the still residual slow conduction here, probably because it's the thickest area. Second remap, still slow conduction here. Again, this is the thickest area, and the final remap is pretty clear. So to conclude, ladies and gentlemen, I think that imaging provides a very valuable information about 3D substrate and about how to ablate the substrate because of the wall thickness and because of the anatomical challenges. And finally, S3 mapping. I think S3 mapping really gives us the full picture of the slow conduction areas in our patient from the very beginning. It's feasible without inducing BT in most of the patient, easy to implement in our workflow, and we don't know yet, we need randomized trial to really prove that by ablating a little more with S3, the results are better. So thank you for your attention, and open for any question.
Well, thank you so much for that talk. Really excellent. A lot of new information for our group there, and really highlights the importance of not only physiologic mapping with S3, but also the imaging. I think the two play a critical role. I see Vivek on. Hi, Vivek. You have questions?
Hi, Ivo. I hope you can hear me. That was a fantastic talk. I was actually listening from the very beginning, but my bandwidth wasn't great, so I didn't want to turn my video on.
No, thank you for connecting to Brazil. Thank you.
No, of course. So first question, you started off well, near the beginning talking about Pierre and Michelle's paper on patterns of the reasons for recurrence. And so I'm curious if you had a chance to analyze some of your patients after your S3 protocol, if you restudied any of them, what are the reasons for your recurrence after your protocol? Is it because of new areas, or is it because of limits of ablation?
Yeah, in ischemic patients, well, first of all, I could tell that I have no recurrence, but it's not true. We have a very interesting study ongoing now. We have published recently the PAMBT study, the post-ablation MRI. We are doing post-ablation MRI study. And we have some examples there of recurrences. And in ischemic patients, mainly it's the same substrate. It's the same substrate. So it's like some kind of, let's say, reconnection of like PVI. We have very few patients with non-ischemic with enough information of the review, but in non-ischemic patients, it's a combination of both, I would say. But in ischemic, I think it's more than 90% is the same substrate. That's why we struggle to do a really complete first procedure. And my feeling is that in ischemic patient, if we can do a really nice first procedure ablation, the recurrence rate is very low nowadays. Not in our hands, in anyone who do a really, with this current homogenization of Luigi, the recurrence rate of ischemic is very low. So I think the reason it's mainly the same substrate in ischemic. Even in the MRI, you can, in the post-ablation MRI, you can see in some patients with recurrences, you see that the channel is still there, or that the channel has a new exit. So it's that you didn't ablate it enough. Sometimes it's because it's very intramural, very thick, whatever.
No, that makes sense. Second, you do have a combination of dilated cardiomyopathy and ischemic myopathy, right? I mean, I know most of them are ischemic, but I know you also have studied dilated cardiomyopathy. I'm just curious if you could just talk about your experience, particularly in the septal substrates with your S3 protocol.
Yeah, in the septal substrate, sometimes it's a bit annoying because you do S3 and you with S3 you see a lot of things, but with S1 sometimes you capture the late potential, and then you don't see anything. So sometimes with a septal substrate, we always look in sinus first. So we look in sinus, we see in sinus, and we have it like a template in sinus, and then we practice the S1, S2, S3, and sometimes S3 it's like in sinus. Yeah, so yeah, it's yeah, I agree with you that septal sometimes it's not as relevant the S3, but if it's really deep, then S3 works again. If it's really deep septal,
makes sense.
And also in small scars, S3 works a lot because late potentials are not very late.
Yeah, that makes sense. The other question is, obviously you're doing this from one location. Do you typically, can you talk about different locations from which to do this extra stimulus? I mean, the fact that you're doing extra stimulus, obviously, it decreases the criticality of where you're doing the stimulation from. But I'm curious, there have been people, I don't remember who it was, Bill Stevenson's group published years ago. Now they weren't looking at extra stimuli per se. They were looking at pacing from different locations. And the one thing I remember is that there was no good rule. Sometimes it's better from the RV, sometimes from the distal CS during pacing. I'm just curious if you've done your protocol from different locations, if you see different things.
Yeah, we have not done routinely. The only cases in whom we try to do it is if the patients have a CS lead. Then if the patient has a CS lead, we try to at least see what happens. And my feeling is that in most of the patients, the deceleration zone doesn't change. So it's true that you see some latest activation that changes, but the deceleration zone doesn't change. But we have not done routinely. Now we have the idea with Andrea Porta that actually it's in our lab, and it's one of the main members in our BT team, and he's trying to start up a protocol. I don't know if Andrea is connected. Andrea, if you are connected, I cannot say this, sorry about that, because I have already started, but he wants to figure out this in an animal model to do a multi-site S3 protocol. I hope it will not change, because if it will change, this is a mess. So how to implement routinely? But my feeling is that the change it's very small in most of the patients.
Can you?
That makes sense. Oh, go ahead, Srini.
Yeah. No, you during your talk, you're talking about your S3 protocol in terms of VERP plus 30, VERP plus 50. Can you talk a little bit about how you came up with those numbers and what you've done to actually come to those numbers?
Yeah, firstly, we started by using VRP plus 20 because it's what is defined by Andreu and Katja Zeffenfeld. But it was defined with S2, and with S2 it's okay. But with S3, if you use 20 and 30, for instance, the inducibility rate is very high. So that's why we then changed to 30, and then we started with 30 and 30, and we still had pretty high inducible rate. And with 30 and 50, we had a good balance between additional information with S3 and less than 10-15% of inducibility rate. It's not very, let's say, scientific, the threshold that we use, but it was the most practical way of arriving to a balance between S3 and non-inducibility. Sometimes in patients with a BT storm, for instance, then we have to increase a little, but it's very rare. In 90% it works.
Yeah. So when you're talking about S3 VERP plus 50, so the coupling interval of S3 is actually longer than the coupling interval of S2.
Exactly.
Okay.
Exactly. Otherwise, you induce a lot. That's why we don't use because the intuitive idea should be the opposite one, like 50 and 30, for instance, or 30 and 20. But then you induce a lot.
Okay.
Now, can I ask you, Ivo, in your S3 VT3 study, I think you said 15 or 18% of the patients VT was induced, right? They went to the side in your flow chart. What happened with those patients? I mean, I guess my question is this: if you induce VT, it doesn't necessarily mean that you can't use that information, right? You can still you can still use and identify deceleration zones before the VT initiates, right?
Exactly. The problem is that for this study, so now we use this information, and that's why I like the case that I showed you, the case in a box, because we induced VT from the very beginning, and we already found the diastolic isthmus. So this is an extremely valuable information. But to measure the number of deceleration zones and the area of deceleration zones, you cannot complete the full map. That's why we said that we couldn't complete the S2 protocol. But again, if you induce it and you have the grid or the penta or the obrel or whatever in the area of interest, the information is very nice. Even by inducing just short runs. I did a one live case before the end of the year, and we induced a short run of BT repetitively. And in the same area, it always starts with decremental activity, unidirectional block, and reentry of 5 or 10 beats. This is enough information.
That makes sense. Can I ask you a technical question? I think all of the maps that you showed were NAVEX maps, and I'm just curious if you used other mapping technologies or something specific about NAVEX that you like.
Yeah. We in the S3BT3 study, when hopefully it will be published soon, we have 9 CARTO cases also. We use more time for BT because we are doing a lot of research of omnipolar technology, and we have a very low inducibility, irritability compared with PSA inside. But for instance, for merging CARTO, it's even faster if you want to merge. But CARTO now has the LAM version, but before the last version of CARTO, you have 2 cases with inside. But yeah, you can do it with the CARTO.
And sorry, just one other quick question with CARTO, because we tend to use more CARTO for VT cases. I think you said pentaray, but I'm not sure. Do you see any difference in pentaray and octaray in terms of irritation for your protocol?
I don't have enough experience with octaray, I could say, but one of my colleagues in Madrid, Javier Moreno, is using octaray. Honestly, he says that for atria, it's amazing, but for the ventricle has the same problem of the irritation. Either you have a huge ventricle, or then you have a lot of irritation. I'm waiting for Ubrel because I have no irritation, and because you have the OT, or even without the OT, the HC wave, the two signals in the same point, I think it's very important. But yeah, I have cases with Carto, and actually, I think my first S3 case was with Carto, I think.
Let me ask one last question. I mean, I'm just thinking about the surgical experience. Sorry, children. Thinking about the surgical experience and how, you know, in the beginning, if you look at the Philadelphia experience, for example, there was a lot of detailed mapping, including extras, including giving procainamide and other things to try to perturb conduction. And then ultimately, they ended up with peeling away the subendocardia, right? At least in the post-MI patients. And I'm curious, you know, our ablation technology, I mean, I'm optimistic that it is going to improve. And I've been optimistic for 15 years, but I feel like we're just on the cusp of seeing something good in the next couple of years, like within the next, 18 months. So as our ablation technology improves, part of me does wonder if the elegance of some of these techniques are going to become obviated. And I'm just curious as to what your thoughts are. And I mean, I'm not really talking about the post-MI patients. I think this is going to be a different animal in the dilated myopathy patients. What do you think about what happens with changes in technology?
Yeah, I completely agree with you that it could be that all of these studies that we are doing, when PFA comes into the field in the ventricle, then what the easiest way will be to put the PFA catheter in the middle of the scar, bam, 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 and go out. Yeah, that's true. I'm not so sure that PFA it's so safe if you have to ablate a lot. So there are some papers now that suggest that that destroying the atria, it's much safer than with radiofrequency, but it's not 100% safe. So I think we will have still some role of mapping with PFA, but for sure the amount of ablation time will be 10 times less, fortunately, because it's the most boring part of the day. So yeah, I think now the limitation for BT ablation, it's not mapping anymore. It's mainly the source of energy that we have. I completely agree with you.
Okay. I guess if there's no more questions, we'll wrap it up for you. I want to thank you on behalf of our group and Vivek for doing this. Really fantastic talk. Certainly going to think about changing our practices based on what you explained to us today. And with that, have a good day, and hopefully we'll see you here in October for the VT Symposium.
Hopefully. Thank you very much for the invitation. Have a nice day.
Thanks, Eva.
Bye.
Thank you.
Bye.
Thank you.
Bye.
Bye.